All right. Hello, everyone. Good morning, America, and good evening, Asia, and good afternoon, the rest of the world, where you are. I'm Alan Yen. I'm an orthopedic surgeon from the Midwest of the United States. I'm your host and program chair of our annual Mount Rushmore Charcot Reconstruction Forum. Welcome to all our physicians and surgeons, scholars, friends, and colleagues worldwide who have dedicated their careers to addressing the diabetic foot disease and take time for our get together this weekend. We are very excited. We're very excited to have our distinguished experts and many thought leaders in the field attend this online conference today. We also give our sincere thanks to all our industry vendors for their support for the entirety of our education event. This is the inaugural conference focusing on the TTT surgery for clinical and research advancement in severe diabetic foot and ankle issues, as well as some updates on the most recent developments and guidelines in Charcot foot reconstruction. So allow me to kickstart this fully packed 5-hour discussion of the surgical management of severe diabetic foot disease. I will moderate the sections together with our international co-moderator, co-chair, Dr. Alex Wee from Frimley Park Hospital in London, United Kingdom. I will introduce our distinguished speakers from my presentation and then each sections. So due to the time constraints, we may have to leave all the questions at the closing section of today's event. So please take short breaks as you need it in between and to stick around to the end, especially our distinguished speakers. And if any of our attendees have any questions, please email our tech team or type in on our chat box. So without further ado, allow me to scratch the surface of this critical topic, and we will learn from our experts from their in-depth discussions later on for this 5-hour discussions today. So also, I apologize. There may be could be some delay or a prolonged in the discussion sections if we have to. So okay, so this is my disclosure, and it's not related to our discussion today. And so diabetes is a progressive, debilitating disease with a staggering number worldwide, despite advances in medical and surgical management. So it's high morbidity and mortality rate, and ended up with amputation quite often. And so it is considered in number wise number one reason for limb loss today. So the established strategy for years, and we have established a multidisciplinary management model for the complex local and host pathology require coordinated care. So that including local IND, very often oxygen therapy, infection control, offloading of various means, and also revascularization or flap coverage, or we using certain skin substitutes for wound healing. So also biomechanical optimization as an orthopedic surgeon contributes a lot to the management of those patients. So the paradigm shift for limb salvage has been a concept in recent years due to the high morbidity and mortality of amputation. However, the limitation of the conventional strategy has its limitations, especially when a host condition is sometimes so compromised that often insufficient microperfusion impairment or systematic conditions of the patients prevent them from any major reconstruction surgery. So we're basically just impossible. So the in the recent 20 years, 10 to 20 years, there is a emergent surgical technique utilizing the Elizarov technique principle and mostly reported in Chinese literature, actually. And with the promising clinical results in, especially in the recalcitrant diabetic foot ulcer patients, including also the non-diabetic PVD, the peripheral vascular disease ischemic patients, and chronic lymphedema is also in the report. So, what exactly is TTT? So, TTT stands for tibial transverse transport. So, it is a clinical extension application of the Ilizarov technique in severe diabetic foot disease. So, how does TTT work? So it's usually, let me describe the procedure to you. It's relatively straightforward surgery with a rather complex underlying mechanism that we are not fully clarified, elucidated. So the anteromedial proximal tibia vertical rectangular corticotomy was performed below the tibia tubercle with approximately a size of 5 by 1.5 centimeters. And that possibly has a function of a reduction of the intramedullary pressure, promoting the blood flow and pain relief. So also, as the Ilizarov technique, we have to apply a stable external fixator, and then using Elizarov principle of rate, rhythm, and the phases. Usually we use a 14 days of medial and 14 days of lateral shift, like a accordion motion, to promoting the neovascularization, to promote the collateral circulation and the transcortical vessel ingrowth to the area. So due to the stable nature of the surgery, this usually right after the surgery, most of the surgeons allowed partial weight bearing. And the frame removal is usually carried out in the outpatient setting in about 28 days. Size and the location of a corticotomy is designed to avoid the stress riser and the stability concerns, and also metaphyseal diaphyseal junctions is chosen to be the regions like most surgeons agrees. And there are studies and hypotheses probing into biological mechanism of the TTT. So this is illustration of one of the relatively straightforward surgical techniques with the original design from our Chinese surgeons team. And we have the honor to have most of the surgeons group here today on our panel. This is one of the most common monorail pattern design of TTT surgery. And the location-wise is usually at anteromedial proximal tibia, below the tibia tubercle. And there are descriptions of minimal invasive techniques to perform the surgery. The surgery itself is actually, to me, is minimal invasive enough in the this population of the patient. And we have our surgeons on our panel list, and with different designs. And later on, we will show you with their rationales and design and outcomes of the surgical results. So the underlying mechanism of the tibial transverse transport is likely quite complex. However, distraction histiogenesis induced by tensile stress phenomenon applied by Ilizarov apparatus is the core concept of the TTT technique. So, inspired by the shaft bow troika, utilizes mechanics to harness horses in Siberia. So this is a fascinating story and how the Elizarov techniques started in Russia. And later on, it started in about 1950s and later on spread to the West and the world since 1980s. And I will leave it up to one of our panelists, Dr. Alexander Kirienko, later on to his fascinating story. He was the chief of foot and ankle surgery for Dr. Elizarov while he was practicing in previous Soviet Union. So the traditional way of Elizarov surgery is usually longitudinal versus a transverse distraction in the lower extremities. And the longitudinal distractions of the proximal tibia usually generate increase in the prolonged blood flow to distal tibia. And also, it's not only the regeneration of osteogenesis, regeneration of the bones, but also regeneration of the tissues. And along with the vascular angiogenesis has been seen all the time from multiple studies from the past until today. So the transverse distraction was purposefully done to increase the size of the size and the girth of the limb of the bones to increase in the generation of the tissue along the vector of the tension of the atrophic bones. The new bone formation parallel to the tension vector either lengthen or widen, either you're using longitudinal or transverse distraction in the lower extremity. So importance here is provided you have a stable fixation with Elizarov apparatus and the maximum preservation of periosteum. That's why the corticotomy is coined and developed with its unique technique, surgical technique. So the transverse distraction was not a new term, and it was described in 1988 for the neovascularization, regardless of the direction. So this is the picture from the landmark paper of Dr. Elizarov from CORR in 1988. So angiogenesis application, the original concept of TTT was already described, but there were no dedicated cases and the clinical application that's described in literature. The other portion of the Elizarov technique is the rhythm, the rate, and the frequency, and along with the law of tension stress. So the hypothesis of tension stress stimulate the stromal stem cells turning on to a hematopoietic and osteogenic precursor cells under desirable conditions, possibly for repairing the bone and tissue defect without grafting or overloads of metal implants. So the orthopedic principles developed by Dr. Elizarov was really a game changer and provided us a means of dealing with very difficult cases. So in China, as the Elizarov technique has spread into China, so the story is Dr. Qulong was first to use the TTT techniques in 2001 and reported in the Chinese literature for Berger's disease, which is thromboangiitis obliterans. In 2008, so Dr. Qing Sihe, who is the chair of the Chinese External Fixation Society, and along with Dr. Qulong from China, established the term TTT in their paper of discussion in the bone transport terminology and Elizarov techniques is published in Chinese. So one of our panelists today, Dr. Hua Qikai, is one of our, has initiated the cases using TTT in recalcitrant diabetic foot ulcerations since 2013. And till today, he has accumulated over 1,000 cases. experiences, and his team has published numerous papers and organized studies, and some of those are randomized. The prospective trial is on the way, I believe. So their first landmark paper in English literature is published in 2019 in the COR, and that was the first one in English literature. So what is TTT is indicated? So this is a paper from Chinese Association of Orthopedic Surgeons. And the group of surgeons from China, they first applied TTT since 2001. And in 2019, their guidelines was a multidisciplinary committee was established. So they also, in addition to the classic Wagner and the University of Texas or International Work Group of Diabetic Foot, the CAOS proposed their comprehensive classification with clinical correlation strategies, especially set it out for TTT. So the comprehensive guidelines from 2019 established principle of the medical treatment, principle of diabetic foot debridement, and the protocols of the TTT surgery. Indication of that, including the Wagner 3 or a Texas 3B or above, and including all the new classifications of 1 to 4 of CAOS, and for patients not indicated for bypass surgery or with the above criteria with the improvement after vascular procedures. So it is contraindication is very commonly contraindicated for other major reconstruction surgeries. So the landmark paper from 2019, or I looked it up, the data published is 2020. So most of the main authors on our panel today, I will leave it up to Dr. Li and Dr. Qikai for their detailed discussions. So on that paper, there are 136 diabetic foot ulcers, grade 2B to 3D, with deep wound and with infections and ischemia, failed conventional management for 6 months, and corticotomy in the proximal tibia with 4 weeks of transverse transport with accordion motion 2 and 2 from medial and the lateral direction. And 136 TTT was compared to 137 conventional management. Both group was offloading offered and regular wound care. So this is the clinical surgical illustrations. And later on, I believe our guest speakers will show you some of very impressive case pictures that illustrate their techniques. So level 2 study of 2-year follow-up of this study, the TTC surgical versus conventional. So the ulcer healing rate is 96% versus a 68% of the conventional management of the diabetic foot ulcer. Major amputation rate is 2.9% versus a 23%, which could be a game changer of a potential game changer of this technique. The ulcer recurrence rate is also much lower, 2.9% versus 17%. Complication is rather simple, common complications we have. 1.5% of the patient has a closed fracture and 2.2 was pin-side infection, which can be handled with antibiotics and local wound care. So there is also a most recent review, which is quite comprehensive. This is published in 2022. It's 20 years development of TTT surgery in China. So the reviews of the mechanism of the potential mechanism of TTT. So here are some noteworthy tested hypotheses in the Chinese literature, however. So TTT has been mostly reported with evidence and influence of macrophage polarization and also growth factor upregulation. So it has been reported of the change of M1, M2 polarization in favor of wound healing with its anti-inflammatory function. The vascular regeneration of the factors changes has been studied, and mobilization of regulation of bone marrow-derived stem cells, which has been called as a summon effect by Dr. Hua, and also related to several expression pathways related to angiogenesis. So this is the paper reported by Dr. Hua, one of our panelists. He termed this as a summon effect or a summon phenomenon, which is treating of the bilateral diabetic ulcer with a unilateral TTT surgery. So that may indicate the systematic effect of the TTT surgery in those patients. So current application in the TTT in the reports are mostly chronic ischemia lower extremity, the Burgess disease or arteriosclerosis obliterans, DFU, or some foot ulcers with non-diabetic causes. So also there are several reports of primarily lymphedema with unknown mechanisms. So this is the trialed pattern of the TTT surgery in the past. The one on the left is from India. The Indian surgeon reported traditional ring configurations in Burgess disease where they're applied. And the middle one is from Dr. Chiu, and far right is Dr. Hua, who is on our panelist, and I will leave it up to him for details. So that design was a consideration of avoiding stress risers and also the capability of accordion motion, moving in and out with compressions and distractions with traditional rhythm and rate. So the variation modifications for osteotomy, corticotomy with more MIS surgical patterns has been reported also. And different combo rhythm rate has been tried to, so there is no final conclusion of superiority at this point. So reported complication in the literature so far, commonly reported as tibial fracture, pin site infection, non-healing, not effective TTT surgery, tibial deformity, osteomyelitis with a deep infection. So the controversies in the report. So limited clinical effect has been reported by some of the report as only 47.4% healing from one of the papers in 2019. And many papers has mentioned it should be done along with the standard wound care, systematic optimization of the patient, and with co-management of a multidisciplinary team model. So despite the potential of a game changer, the limitation and conflicting results of existing studies justify the need for further research into this and optimal the application and development of the techniques was fitting for our very difficult to treat patients population. So there are also papers for the learning curve, which is authored by one of our panelists, Dr. Zhao. The cutting off point seems to be reaching about 20 cases in a single surgeon's series in 1 year. Also, the multi-center prospective study from 2016 and 2019 was carried out as also by one of our panelists, Dr. Hua Qikai's team. And later on, we will listen to their details of their discussions. So in his papers, the protocols has been established, and also the outcomes and life quality scores with a quite impressive result, with a healing rate of 94.9 in that prospective study. And time to healing is about 12 weeks or so. And the major amputation rate is about 4.9%. And the recurrence rate is about 3.1. Closed tibia fracture is 0.7%. Pin site infection is about 2.1%. Infection of the corticotomy site of the TTT surgery was 0. So limb salvage in face of diabetic pandemics. So this is likely the last resort of the systemically ill patient, a fragile patient. Otherwise, has no options other than amputation. And we know the consequence of an amputation is quite morbid, and you can compare it to some of the cancer patient. So the microperfusion impairment frequently seen in those patients may exclude effective revascularization procedures and it may benefit the procedure most. Today in our panel, also we have our thought leaders of vascular surgeons, Dr. Joseph Mills, and we will listen to his insights in dealing with this very difficult patient's population. And nowadays, we has consider the time is tissue and the same saved limb is equals to a same life. The principle has been established. And we require coordination, cooperation with multiple centers of the surgeons and researchers of different specialties. And so that's in order to benefit our patient worldwide with our coordinated care. So many questions still remain. What's the exact biological mechanism? Is the local or a systematic immunoresponse or combined or anything beyond? Increased use with increased reported complications is also we can see in the literature, and however the English literature is limited. So we need to elucidate the basic science evidence with further higher level clinical evidence. Most comprehensive review to date is 2022, Dr. Liu's paper. So I love this quote. There are three types of person in the world, and the first type is those makes things happen. Those who watch things happen is the second type, and the third type is those who are wondering what happened. We all have a choice, and you can decide which type of person you want to be. And I have from Mary Kay, and she is always the one chosen to be the first group. So I'm very excited that we have our panel of extraordinary expertise in this field today. And we get together and starting from our very first Reconstruction Forum online, and international attendees and join in with us, have a great discussion. So this is the literature has been included in my talk. And so we have a couple of different sessions. And first, we will start with the Asian Pacific Experiences session. I will introduce our panelists one by one on their session. And then we have our keynote speakers, Dr. Gang Li from Hong Kong, China, and Dr. Dan Wukich from Texas. And also our industry speaker, Michael Theodolo, will present us with a new design in his technique of TTT. And our panelists from US, and we shift our attention to the charcoal reconstruction updates. Please stay with us. And we also have our final discussion, and also we have our OrthoFix speakers today, and we really appreciate their support. So without further ado, I will leave the next speaker on stage, and Dr. Hailin Xu from Beijing, China. Dr. Xu, if you are ready. And Dr. Xu and I has been friends for over 10 years, and he is one of the young leaders in China Foot and Ankle Society. He has a very close tie with the international community of Foot and Ankle Society, and he is also an international member of AOFAS. So, Dr. Xu, please start your discussion.
Hello, Alan. Hello, everyone. Good evening, because in China it's evening, and also thanks Alan for organize so successful meeting for TTT. Okay, we also do a lot of TTT operations. So I show my PPT. Everyone, my term is the application of a double bony flap TTT. So just take it DTTT technique is one of the technique of TTT operation. I'm Hailin Xu from Beijing. I'm from Foot and Ankle Center from Peking University People's Hospital. So welcome to Beijing. So the mechanism also just Hailin have introduced very good. So I just introduce my technique. So because a traditional surgical site and incision is at the midshaft of the tibia, also a very large incision, so have many disadvantages. So now in China we have modification. So mainstream of TTT techniques includes two techniques. The one is single bone flap. Just Dr. Hua and Dr. Li Gang, Professor Li Gang have do it, and they will introduce it. And the second is a double bone flap DTTT. It's our approach. So it's just the site is located below the tibial tuberosity. And also the tibial osteotomy windows are two vertical squares, each with a side length of 1.5 centimeter. So two bony osteotomy, with a very small incision. So key surgical step is so Hailin, if you can see my video.
Yeah, we can see the presentation.
Okay. So I think longitudinal incision or two small incision with osteotomy and use a drill with a specialized osteotomy guide to make the procedure very fast. During osteotomy, gently tap with a small osteotomy, aiming to preserve the periosteum intactly. Use a local anesthesia, so make the patient safely. Use a specialized osteotomy guide to do the operation, so very fast. And two bony flap. So when test it's okay, so we can finish operation. So the DTTT learning curve is very easy to perform. If you do about 20 operations, you can do it very fast. And the post-operative management protocol is post 3 days after operation, we can waiting the initial tissue Hailin, and then we can do the distract 1 millimeter daily for a total of 14 days, and then double the rate during the return transport phase. So it's 21 days, and after that, 3 days ago, 3 days after, we can take out the external fixators. So the totally phase is 1 month. It's we do the X-ray after the operation for 2 weeks after we distract the bony segment. is a segment 2 weeks. So general post-operative management is use sensitive antibiotics and use a masquerade technique to treat the wound. Also, we can begin wet bearing with a brace, and also reassessment with X-ray to confirm or secure the window healing before resume normal activities after 8 weeks. And precautions, importantly, is one is anticoagulation. Just we admit a low molecule heparin for 2 weeks is okay. And the very important is how to discharge the bone, because they need the patient's accompanier or his mate to do it, so we can give him fill out the form. Every day, just 4 time points. If he finish 1, he can just fill out the form. So make the procedure successful. So this is very important to do how to discharge the bone. It's very important. So treatment strategy is for Professor Li Gang. So every types of the DFU we can use this TTT. So it's our case. The one case is 67 years old female patient with ulcer over 3 months, and is very poor result. So underwent DTTT and deployment. 3 weeks have a good healing. Second case is a 46 years old male with diabetic foot and gangrene of a great toe for 1 month. So we do a DTTT after one month, very good healing. Case 3 is a 68 years old female with ulceration and right second toe and plantar surface for 1 week. So we do a DTTT, and also 3 weeks is very stable, and 1 month good healing, and 2 months very good healing. Case 3 is a 50 years old male patient, and 3 weeks we do TTT, and just 3 weeks and 2 months very good healing. Case 5, 53 years old male patient, over 3 weeks, and do TTT 1 month good healing. Case 6, 60 years old female patient, 3 days, and do TTT 1 month good healing. Case 7 is a very impressive patient, 45 years old male patient who had undergone multiple lower limb vascular interventions. He have do 3 operations about vascular interventions and failure. So he came to me to do the DTTT. After the operation, it's 2 weeks, very good, and it's 1 month. So 1 month and 6 weeks, because we want to preserve his first metatarsal head. because he's a young patient. So 52 days, and after 2 months, the operation we do a radiography, and it's before operation, right foot like this, and 2 months after, I have a very good increase. Very both the patient say it's crazy, it's amazing, very good changes. And 6 months has good healing, and his video have a very good cover. And it's 2 patients. It's have a CTA examination at post-operation 1 year. So right foot total operation. So at 1 year after operation, also keep very good. So we have do some studies about TTT. So one is biomechanic analysis. We do a dynamic finite element analysis, and also do a mechanic testing. We compare the double window and one window. So we found the tibial exhibit superior axial compressive and torsional resistance is better compared to the single window approach. So we also do a retrospective analysis of TTT, and we 2021 we have published a paper. We do 200 patients and have a very good result. Also, until today, we have do over 1,000 operations. Also have a very good result. We also have do a mortality analysis. A total of 46 patients, and with 9 patients deaths reported. Among these, 1 death were due to pulmonary infections and 5 due to cardiac causes. And a summary of my DTTT technique: a complex systematic procedure with a long duration and multiple intermediate steps. So is it absolutely necessary for wound healing? Maybe. Are there better alternatives? We'll study it. We can give a very good. And also, it's a relationship with vascular intervention surgery. I think the vascular intervention surgery is have a very better results if the two have compared unit. Also, in our 1,000 operations, we have 25% patients we add the vascular intervention, and the other 75% we just do DTT and have a very good result. So thank you, thanks, Alan. Thanks for your attention.
Thank you very much, Dr. Xu. Thanks for the excellent presentation. And we move on to the next presenter. Our next presenter is Dr. Qikai. He is the man behind the TTT, and the multiple critical papers was published from Dr. Hua's group. He's from Guangxi Hospital from China, and he's one of the director and the leadership in the Chinese External Fixation Society, and one of the very early adopter and the man behind the protocol development of CLOS on TTT surgery. So Dr. Hua is going to present the part or entirety of his slides in Chinese, and we have Dr. Yongsheng, Chen Yongsheng from Singapore is going to translating at the same time. Please go ahead and start your presentation, Dr. Hua, when you are ready.
老师您在吗？到我们了。
我在的。
好，谢谢老师。Good morning, good evening, everyone. I'm Yongsheng from Singapore. I'll be translating for Professor Hua, who hails from Nanning, Guangxi, and he's the chief of unit at the Guangxi's Guangxi Medical University and First Affiliated Hospital.
好啊，谢谢严教授，谢谢永胜给我的翻译。在这里呢，我跟这个世界的各位同道，就是做这个糖尿病足的同道，分享一下我们用胫骨横向骨板仪治疗糖尿病足11年以来的一个心得吧。我们是2013年开始做的。
老师帮你翻译一下。Professor Hua says thank you to Alan and thank you to the audience, the wide audience worldwide for listening to our talk. And he would like to share his experience in using TTT to treat diabetic foot infections over the last 11 years. And he started doing this in 2013, I beg your pardon. 好
TTT 技术来源于伊利扎诺夫先生的张力应力法则。
The basic principle behind behind the TTT technique is Elizarov's principle of the law of tension stress.
这项法则的核心内容就是骨与软组织的再生。
Okay, so the main effect of the law of tension stress is that it helps in the regeneration of not just bone, but also active tissues and specialized tissues.
所以这是一项再生理论，它有别于我们其他的外科技术。现在其他的外科技术都是移植为主，我们这个是再生技术，张力应力法则。
好，帮您翻译一下。
你帮我翻译一下。
Professor Hua would like to emphasize that on the principle of regeneration, and then he says that the main effect of this law of tension stress on the TTT is that of regeneration. He's using this technique to regenerate tissues and not a tissue transfer technique.
非常感谢严教授和徐教授之前的介绍。我们的 TTT 技术是一个非常安全并且高效的骨科小手术，这个我们已经有发文章去确认了。
好的，帮您翻译一下。Thank you, Professor Alan and Professor Shi for introducing the technique. Professor Hua would like to emphasize that this is a minimally invasive technique that is safe and effective, and the technique has been published before.
所以这11年来的大量的就是1000多例的这个 TTT 治疗糖尿病足的病例，给我最深刻的印象就是这项技术是一项再生的技术。
好的，帮您翻译。So he'd like to emphasize that the most impressive finding of TTT is that this is a tissue regeneration technique, unlike all other procedures which rely on tissue transfer.
我们团队将伊利扎诺夫先生经典的 局部骨再生，运用横斑将它的原理外延到全身的软组织再生。
好，明白了，跟你说一下，帮你说一下。So, Professor Lizarov popularized the technique of distraction osteogenesis, but actually TTT goes beyond osteogenesis. It involves the regeneration of other tissues, even the soft tissues. And I think the term to use now really is a distraction histogenesis, because it's not just the bone that's regrowing, that's also other soft tissue structures.
这一个病例是一个65岁的男性糖尿病足病人，他的足部皮肤完全的感染缺损了，并伴有坏疽。
好的，帮你翻译。This is a 65-year-old. This is a 65-year-old gentleman with severe necrosis and infection of his foot. There's also exposed bone and the severe necrosis. Yeah.
通过 TTT 的治疗，我们可以看到他的全程皮肤是以再生的方式得到了愈合。
So after TTT treatment, you can see that all the dead tissues having been removed and have now been regenerated to healthy tissue.
这是一位72岁的老年男性，他面临着肱骨大段的外露，糖尿病足。
This is a 72-year-old gentleman with a diabetic foot ulcer. 肱骨外露 is with an exposed calcaneum. Yeah.
Yes. 通过 TTT 的治疗，可以在骨面上长出新鲜的肉芽。
So amazingly, with TTT, you can actually use this technique to induce granulation and regeneration of tissues, even on bare bone.
2个半月，病人得到了完全的愈合。
And this patient amazingly has healed completely after just 2.5 months.
这位病人是56岁的女性糖尿病足病人，她面临的困难是肌腱的外露。
好的，帮您翻译。So this is a 56-year-old lady, and her critical problem here is exposed tendons.
我们同样可以用 TTT 技术进行再生的完全的愈合。
Similarly, we can use TTT to induce a regeneration of tissue over the exposed tendons, leading to complete healing.
这是他1年半以后的随访的功能项。
This is the follow-up video showing her function at 18 months post-operation.
它的功能完全保存，没有任何的丧失。
There is a preservation of the majority of her function with a minimal functional loss.
这位66岁的男性糖尿病足，第二指末端8个月的创面难以愈合。
This is a 66-year-old male patient with a necrosis of the tip of the second toe, distal tip of the second toe.
经过 TTT 的治疗，新鲜的肉芽正在生长。
And after TTT, you can see regeneration of the tissues, and where there was a complete necrosis previously.
1个月后，指甲完全再生。我们知道指甲是特殊的皮肤。
Even specialized structures such as the toenail can regenerate with the help of TTT.
这个病人面临着 严重的截肢风险，因为他的关节、骨头和肌腱都由于感染外露，而且产生大量的软组织缺损。
好的，帮您翻译一下。This is a patient with a high risk of major amputation because he is facing the problems of exposed bone, joint, tendons, and all the critical soft tissue structures.
并且还有严重的脓毒血症。
And there is a severe pyogenic infection with purulent discharge.
Yes. 这是手术当中的录像 video.
This is the intraoperative video showing the extent of the infection and he's septic.
通过 TTT 的治疗，我们可以看到它以一个再生愈合的方式将肢体保全了下来。
With TTT, we have successfully managed to avoid an amputation and successfully salvaged this limb, as well as to create the soft tissue cover for this patient.
这位病人不需要用皮瓣的移植和植皮来进行这一个创面的覆盖。
好的，帮您翻译一下。So, Professor would like to emphasize that this coverage was done purely with regeneration induced by TTT. There was no need for any soft tissue coverage procedures like flaps or skin grafting.
我们做了这些病人的治疗前和治疗后的 CT 下的动脉造影。
This is I think a CT angiogram picture showing the top row shows the preoperative status and the bottom row shows the postoperative status.
治疗后的血管明显比治疗前的血管要丰富，血运也要丰富，然后有统计学差异。这一个图片是我们发表在 Core 上面的。
This is a finding that was published in the Core COR journal and shows a significantly increased vascularity after intervention.
这个是另外我们发在 JOT 上面的，也是另一组病人我们做的这个血管影像，都客观反映了这个病人治疗后比治疗前他的血运得到了极大的改善。
This is another paper that was published in JOT, which again shows that after intervention there is a objective increase in the vascularity, the limb.
我们取病人的创面边缘，在 TTT 术前和 TTT 术后1个月做的一些病理切片的检查，我们可以看到有结构恢复，有胶原重塑，有增殖活跃，还有血管的新生和腺管的再生，这一切都昭示着我们的组织是一个全层皮肤的组织再生。
我试看帮你翻译。I'll try this. I'll try this slide because this is a bit technical. So I think this is histological analysis taken at 1 month after surgery. And this is the histology of tissues taken at the edge of the ulcer. The first row shows the findings prior to surgery, and the second row shows the findings 1 month after surgery, and it's broken into different columns. The columns purportedly demonstrate a restoration of 结构 structure and 胶原重塑. I don't know what's the second one.
Muscle.
Oh, okay. Muscle. The second one is regeneration of muscle. The third one shows tissue cellular
Yes.
activity. The third one should be an endothelial kind of growth factor. So that's 血管新生 means neovascularization. And
Yes.
腺管 means glands. I think even the sweat glands and glandular structures, specialized structures such as glands are also regenerated. 应该是这样子。
哎，对。这个病人是一个58岁的糖尿病足病人，出现了足底的皮肤缺损，由于感染造成的。
好的。This is a 58-year-old gentleman, patient with a diabetic foot ulcer, and this is a plantar aspect. You can see in the plantar aspect, there's a lot of soft tissue loss due to infection.
经过 TTT 的治疗，缺损的组织得到了再生的愈合。
So with TTT-induced tissue regeneration, we're able to achieve coverage of the wound defect.
再生的组织明显有神经反射。
So, Prof would like to emphasize that the tissue that is that is regenerated at this injury site actually is sensate. So that means that the specialized structures such as the neurons are also being regenerated here. It's not just a pure insensate wound coverage.
这是一位80岁的老年女性，足部的感染坏疽，也有脓毒血症。
This is an 80-year-old lady with a severe infection of the foot and septic. Septicemia.
Yes. 清创清除坏死后，出现了非常巨大的软组织缺损和骨的外露。
After debridement, there is an ensuing resultant soft tissue defect that is very extensive, and there is exposed bone as well.
经过 TTT 的治疗，我们可以看到肉芽从一种不健康的状态进入一种长势良好的健康状态。
好，帮您翻译一下。So after the TTT treatment, you can see granulation. Initially, the granulation looks fluffy and unhealthy, and after a period of time in the treatment process, you can see that in the third photo, you can see that the granulation is now of a very healthy character.
由于病人不愿意植皮，所以经过7个月的创面换药治疗，这一个创面得到了最终的愈合。
So this patient was unwilling to undergo skin graft and skin flaps. So this wound was healed completely using TTT and conventional wound care alone.
这个病人长出来的这一块组织是有感觉的，用棉签棍可以刮出感觉。
So the regenerated skin is actually sensate, and she can feel, and you can induce a reaction on the new plantar skin.
这个病人是68岁的男性糖尿病足的病人，在别的医院做了截肢，伤口感染不愈合。
So this is a patient who had an amputation in another hospital, and unfortunately, the amputation stump was complicated by non-healing and poor healing. So what he's done is he's done a TTT on the contralateral side.
我们在对侧做的 TTT 可以看到肉芽已经开始在健康的生长。
Okay, after TTT, we can see that there's a significant granulation tissue.
经过非常良好的创面换药治疗，我们可以看到创面得到了一个不用植皮的痊愈。
The wound has healed completely with just conventional optimal wound therapy, without wound care, without any need for skin transfer.
非常有意思的是，它的创面带来的同样是有毛发的生长。
You can see that even the hair has regenerated even at this amputation stump, suggesting that it's not just the skin that has regenerated. Even specialized structures such as hair follicles are regrowing. 汪老师，我们还是
所以
有
所以我们可以看到 TTT 带来的再生，同时我们还能看到一侧肢体的 TTT 可以带来两侧肢体的再生，所以我把它这个现象称为召唤效应。
好的，这个我帮你翻译一下。So basically, Professor Hua is saying that he believes that TTT has a systemic effect. And it doesn't just work on the ipsilateral, the same limb. It has a systemic effect. So you can do TTT on one limb, and that can induce healing in both legs, for example.
这个病人是62岁的糖尿病足伴有肾衰的，就是做血透的病人。由于他非常的贫穷。
This is a poor patient with diabetic foot ulcer, but however, he also has end-stage renal failure and he is on hemodialysis, and he's financially poor.
一开始我是打算只做一边的这个 TTT， 等他这边好了以后，左边好了以后，然后免费给他做右边的 TTT， 为他节省费用。
Oh, I see. Okay, 好，明白。我跟你说一下。So because he's very poor and he cannot afford implants on both sides, this initial Prof was trying to do was just to do one-sided TTT, hoping that he can cure the left side, and then maybe the right side he would do it, then do it later.
但是他只做了左边的 TTT， 然后两边同步在愈合，两侧的足底同步在愈合。
However, to the team's surprise, he only did TTT on the left side, but actually he found that both heels had recovered. And this is
然后术后4个月，两边同步痊愈。
And 4 months after left side TTT, bilateral heels have recovered.
所以有了召唤效应以后，我们这些两边病变的这个糖尿病足，我们只要做一边就可以让它两边同步愈合。
With the summoning effect, with the systemic effect, even if you have a foot with bilateral necrosis, you just need to do TTT on one side, and that can lead to the healing on both.
这是在愈合过程当中的记录。
These are the photos showing the process of healing.
术后8周，基本愈合。
This is 2 months.
这个是夹着。
Yeah.
这是术后1年，我们到家随访，到病人家里头随访，
去到病
可以
人家。
看见他，对，去到病人家，可以看到他完全恢复了生活。
好，so this is the treatment team going to visit the patient at her house, to follow up, and you can see a function, and both feet have completely recovered.
所以针对召唤效应，我们也做了动物学，这个以及相关的基础实验以后，我们总结发表了文章。
So they have published animal studies and basic science studies as regards to the summoning or the systemic effect, and this has been published.
同时，我们发现这些创面得到一个健康愈合的过程，这一个由 TTT 引起的炎性调节，也在这个治疗过程当中发挥了非常重要的作用。
I must say I'm not quite sure whether I got this, but I think he's trying. Prof is trying to say that there is an immune modulatory response after TTT. 炎性调节
炎性调节
inflammation
炎症
modulation
inflammation
inflammation modulation yeah
yes 所以这个就是一个 M1 型和 M2 型这一个巨噬细胞在这个创面得到了一个有效的平衡，所以才得到了一个漂亮的创面。
Okay, this part I had, but essentially with the immune modulation, I think that has brought about such a dramatic response in the tissue healing. Sorry, I don't quite know what
Yes.
M2 and M1 is, but I suppose that's okay.
所以有召唤效应以后，我们甚至手部的糖尿病感染也可以用 TTT 进行治疗。
So because of the summoning effect, because of this systemic effect, he can use TTT on the tibia to heal diabetic hand infections and diabetic hand necrosis as well.
这个糖尿病的这个手部感染清创以后出现的软组织缺损，我们同样经过 TTT 的治疗和这个创面的精确换药，也得到了一个很好的保治效果。
So this is a diabetic hand infection, and all he did was TTT in the tibia and conventional optimal wound care for the hand, and the hand is healed nicely. That's the functional video.
这位72岁的老人，他的手部功能基本上足够他的生活。
He's able to use a chopstick better than me. Fantastic.
这个是中国的一个传统美食，叫做芋头。各位如果感兴趣的话，可以来中国品尝。
This is this traditional Chinese cuisine. I think it's tapioca or yam. Yeah. Welcome to come to China, and he'll treat you to it.
所以我们有这么多病人的总结，我们给出了 TTT 的适应症，就是如果应用经典的糖尿病足治疗方案失败或者无效的病人，可以用 TTT 来进行挽救。
老师，我帮你翻一下。So this slide talks about the indications for TTT and when he would use indication TTT, and the words in red says that when classical treatment modalities for diabetic foot infections have failed, that's a good time for you to use TTT.
这个病人是66岁的男性糖尿病足的病人，敷了中草药以后出现皮肤的这个烫伤和感染坏死，在我们国家的一个著名的创面治疗中心进行治疗。
我帮你翻一下。So this is interesting. This is a burns injury, and the etiology for the burns is actually traditional medication. So he has received a traditional treatment and applied something on the foot, and that's caused a burn. This was treated at a specialist burns unit elsewhere. Yeah.
第一期治疗，它是这个创面治疗中心给他做了清创和负压吸引，就是 VSD 负压吸引，而创面反而更糟糕。
So this patient, because was treated in a burns unit, had debridement and VAC therapy, negative pressure wound therapy, and after VAC therapy, actually there was a further progression of the necrosis.
然后用了第二次治疗，就是用我们最容易存活的小腿带地皮瓣，就是腓肠神经营养皮瓣，来覆盖这个创面。但是很遗憾，这个创面死了一半，活了一半，这皮瓣。
这是琉璃皮瓣吗？
啊，不是，这是带地皮瓣。
So this is a local flap.
就是小腿后侧皮瓣。
好。It sounds like hemisoleus or one of these local flaps that was done, but unfortunately half the flap survived and the distal half of the flap necrosed. 好。
然后他第三次治疗又用了这一个抗生素骨水泥的覆盖。
This 抗生素骨水泥 is PMMA, so that's antibiotic cement. So this was covered with antibiotic laden cement.
最后呢，残留了这个距骨的骨髓炎，出现了骨外露。以及关节外露。
Unsurprisingly, this was complicated by exposed bone, exposed tendon, exposed joints, and chronic osteomyelitis.
然后这个时候，病人转到了我们中心进行治疗。
At this point, the patient was transferred to our unit.
我们给他做了 TTT， 同时把这个骨面的坏死。就是这个是根，这个是头骨，这根骨和头骨的坏死骨面进行了一个非常小心的清理。
So it's done a meticulous debridement of the calcaneum as well as I think the talus, and that's wound care. Yeah.
我们看到这个创面虽然是有骨的外露，但是经过 TTT 的治疗，首先骨头能够被肉芽所覆盖，其次皮肤可以顺着这一个创面进行爬行，最后得到了一个完全的愈合。
So the surprising thing over here is that even though you have bare bone that's being exposed, that TTT can induce granulation tissue to form over bare exposed bone, and the granulation tissue is then subsequently covered by normal skin.
所以病人也就能够这个走着回去了。
And the patient managed to walk out of hospital.
但是我们也有3%的病人，3.5%吧，3.5%的病人没法保支，这是由于这一个血管实在是就是完全堵掉了，就是糖尿病足加动脉硬化闭塞症的病人，我们经过努力也没法保下来。
There are proportion of our patients whom we are not able to save with TTT, and this takes about 3.5% of our total patient population. And
你可以简单的类比一下，就叫沙漠上是长不出草的。
You can't grow grass in a desert. So I think he means to say that it's completely barren, and there's no possibility of any regeneration in a proportion of these patients.
就是这种第二片上面看见的这种血管椅，我们解剖了以后就发现，它完全堵掉了，而且都是形成了骨化这个动脉。
So just now in the previous slide, Prof was emphasizing the calcification of the vessels. And after the amputation, this patient was not able to be salvaged. When you examine a cutout of these vessels, you can see that vessels are completely occluded and calcified.
这个是病人的颈后动脉，可以用这个血管直接就可以把它竖起来。所以这个就是 DF 加 ASO， 是我们TTT 面临最严峻的挑战。
So ASO refers to arteriosclerosis obliterans. That's a condition that I'm not too familiar with, although I tried checking that up. But he says that patients with this disease coupled with diabetic foot ulcers are the ones who don't seem to respond very well to such treatment.
但是这一型的病人也不是完全的绝望。我们如果能够做到就是那个 PTA 就血管再通的话，依然有希望能够把这一类型的病人能够挽救回来。就像这个病人前足完全坏疽了。
So even in such patients, it is not totally hopeless. If you're able to restore the blood flow to the limbs, you can still salvage these patients.
他的在介入治疗过程当中，我们可以看到他的膝下就是这个从国动脉开始完全堵塞，但是很幸运，这个病人能够打通血管。
So you can see in that patient, there's a complete obliteration of flow infrapopliteal. So below the popliteal artery, there's no flow at all. Unfortunately, we're able to restore flow through a vascular procedure.
血管术后，我们即刻就把这个坏疽的前足给它清创拿掉了。这个裸露出来的整个足的创面，我们可以通过 TTT 让它顺利的愈合。
So the full extent of the necrosis after angioplasty was removed and debrided, and if the bones are exposed, so be it.
最后达到完全的愈合，不用植皮。
And at the end of the day, you can get complete regeneration and healing. There's no need for skin graft, skin flap.
这就是我们发的第一篇 TTT 治疗糖尿病足的这个英文文章，在这个 Core 上头，2020年发表的。
This is Professor Hua's landmark paper in CORR 2020.
然后这是我们写的就是编写的一部中文书籍啊。
And this is a beautiful textbook with lots of photos. It's written in Chinese, and the editor is Professor Hua himself. It's a really good book.
我正在把它翻译成英文。
He's in the process of translating that into English.
我们也开展每个月一期的这个学习班。
Every month.
目前全国都有了，都有医生来。
He conducts a class for the whole of China, for surgeons all over China to come to visit him, to see and observe and learn this TTT procedure, so that they can bring this technique home to wherever they come from.
这是我们做的一些世界性的交流，也有日本的医生、美国的足踝外科医生来我们医院一起手术交流。
And he has visitors from all over the world, from Japan and other places, who come to visit him and to share the knowledge.
这位是德国慕尼黑大学附属医院的 Taylor 教授。THALLER Taylor.
This Professor Taylor from Germany, and that looks like his publication.
他在德国读了 Core 的文章以后，在德国应用 TTT 治疗糖尿病足也得 到了很好的效果，并发表了论文。
He has after reading Professor Hua's paper in COR, he himself has tried doing TTT in his own country, and he's got good results, and he's published his results in this paper.
Taylor 教授是在就是水内肢体延长，是非常有造诣的学者。
水内肢体延长，
水内就是水内顶延长肢体。
Okay. So he's an expert in internal lengthening nails. I think that's what Prof is saying. Yeah.
这个就是陈永胜教授在新加坡应用 TTT 救治病人的报道。
This is some work that we are doing in Singapore, which I'll be sharing later. Thank you, Professor Hua.
祝贺陈医生、陈教授。这个是越南的丁文水主任在越南应用 TTT 救治越南糖尿病足的病人。
This is a colleague and a professor in Vietnam who's sharing his work using TTT in his hospital in Vietnam.
然后我们也得了一些中华这个叫做华夏医学奖和广西科技奖，也获得了一些政府的这个认证吧。
恭喜老师。So just congratulating Professor Hua on receiving his local and government award for his life work in limb salvage using transverse tibial transport.
最后就是非常感谢各位的聆听。我想强调一下 ，TTT 它不是一个手术，它是一个治疗过程。在这个过程当中要有耐心，要注重细节，要对创面进行合理、及时、正确的判断和处理，才能让它的再生效应得到最大的发挥，从而达到最好的保治治疗效果。谢谢各位，谢谢陈教授。
谢谢华老师。Professor Hua would like to reiterate a few points. He says, first of all, he says, thank you everyone for listening to him and giving him the opportunity to speak. He would like to emphasize that TTT cannot be viewed as a simple and as a standalone procedure. We need to focus on the details of the treatment and the intricacies of the process in treatment, particularly in the wound care and respect for the soft tissues and other factors. Thank you very much. 好，谢谢花老师。
Thank you.
谢谢。Thanks, Dr. Hua. Thanks, Dr. Cheng. It's amazing reports that we have. So I apologize that I as a program chair, I'm responsible for our lagging behind our schedule right now. So if we can, the following presenters just pay attention to the chat box. Some housekeeping items in chat box if we set it out 5 minutes reminder. And okay, so without further ado, we let's introduce the next speaker, Dr. Jiang Xiaorui. He is a renowned surgeon specialized in diabetic for the ankle disease, and he's also the director of endocrinology for the ankle department in one of the major hospitals in Shandong. And he has around 2,000 cases of complex for the ankle reconstruction for diabetic foot each year. And now let's have Dr. Zhao introduce his cases, and we are all ears. Dr. Zhao, please.
Okay, thank you very much. Thank you, Dr. Yan, the introductions. So I will introduce my PPT in a short time. Maybe I need the help from the Chen Wang doctor. The first, good morning. I'm Dr. Jiang from the China, Yantai. My topic is today is the TT surgery, complication and failures in the TTT. What we have learned This topic is given to me by Dr. Allen. In PPT, I will introduce some common complications about more than 200 cases of the TTT surgery I have done, and how to avoid complications. So this is my approved introductions, our hospital and our department. We can service every year more than 800 diabetic foot with Wagner 3 or Heiner's diabetic foot. I'm leader this department. This department is MDT department. You can see different kind of daughter. Okay. This picture shows the more than 500 million people in the world, and 10% to the 15% developed diabetic foot. China has become the highest incidence diabetic foot in the world, and about 4 million new diabetic foot users are ended every year in China. So I will show some work. We can show different diabetic foot. On our teams, we can treat all times and diabetic foot like this. It's serious infections. We can use the flap and skin grafting and repair the wound. We can use like this simple fixtures and repair these bones exposition and like this. Every year we can done more than 150 lunar extremities arterial interventions in years like this. We can do more than 150. We have good functions. And this traditional technique need autologous with grafting bypass for repair. Yes. So we can repair the foot. This bypass the vein. So I will show my TTT case. The TTT case, I can do this work from the 2016 years. I have done more than 200 cases with direct help from Professor Hailin Xu. He gave a lot of the help. So we can see we can go to repair, and temperatures, the foot temperatures is good. The temperature of the foot is better than health side. Okay, this is another case. This patient had infections and food ischemic. I have give this TTT service, and these people have no money, so they accept treatment at home. So we cleaned the wound. So every day change the dress, so we get better, make the wound heal. So we can see this video. This lady is very happy. Okay, this video tells us I suggest my patient should go to the ground working after 3 days. 3 days after surgery. We can say this lady is very happy. So I think the TTT not bring pain to the patient. Okay. Although TTT operation is simple and easy to perform, but some complication, especially for the inexperienced daughters. It easily occurs, and the patient is diabetic. there are three factors is most in the diabetes phase. The first, like this patient, it after surgery TTT 4 years and end up again with amputations. We found after 4 years, this bone block not heal with another adheres bones. So we can see this wounds is not healed, and this gap still in here. So maybe why happen this? I think the osteoporosis is the most causes. Another is we can see the skin of the tibias, neck sources. We can see the bones. It's very terrible. If this disease happens, maybe we need a long time repair this to the wound or cut this to the leg. So it's on health scale. Another is the VTE. I think that in my patients, more than 5% the patients have the VTE, and the two reasons is dies the DVT. So the first, we can show this the TTT. This patient go home and slid down the ground. He felt the pains in the tibia, so we found the fracture in here. But it looks normal. So we must remove this external fiction and give the cast. After 2 months, it's a recovery. So why? So we can see this. This is a cross-sectional anatomy of the TTT surgery scar tibial. We can see this part, its tibials is not a regular oval shape. Sometimes these zones, it's I think it's very important. It's the main loading body the surface in here. So we must make joints like this. It's not straight like this. If you make streets, make roads like this, maybe make the fractures. So so tells us the second istomy should important. The second istomy should be made medially, and the laterally and medially distance between the lateral and the medially side should be reduced to 2:1. So the second, the complications, we can see the severe skin necrosis. Why? I think this necrosis have 3 points. The first, we control controls infections. The second is the lunar's amputation. The second is limb still excite acting the infections has not been effect control, and maybe the second is hematoma. The third operation is to roof cause the skin's necrosis and pulling these bones. The scale, the tension is too large. So we look at these cases. This patient was on day 5 of the operation, had not started lifting and carrying. The skin of the tibias appears red and swollen and oozing. By TLC culture suggest MSSA. We gave a 4-dose cephalosporin, but it doesn't work. So we get remove this this fraction. So we give good drugs. For example, laser lead and suture this wound. So it's terrible. Oh, so I will introduce my method operations below. We can see this. I describe method operation below, which the objectives avoid hematoma as well as dislocation bones, bone blocks and no heals bone, and mentioned earlier. I first draw the holes in here, and then I use a small blade to peel osteum. We can get a 5 millimeter gap. It's very important. So, and suture the pure osteum. So we can see this tractor bars is very stable. Very stable. And the position bones is firm, which will also minimize bones no healing, dislocation, and prevent hematomas formation. Then another indications, I think these four is very important. The first, the patient have ability to work. So I think another very important is at least one more blood vessel below the knee to the joint, ankle joint, and forms the vascular network. Sometimes I like this. The first make the joints, we can see the blood flows from the medullary. If the sees the blood, so we can see the it's red bone marrows. But no, you cannot the blood. It is it's the yellow bone marrows. So it doesn't if it's the yellow bone marrows, it doesn't work. If you use the TTT survey. So all the case though, I used the Wagner 3 and 4. We used the TTT survey. We call the TTT surveys in past more than 60 years. We can see valuable data in that. We can see the patients have skin necrosis. We need more time to repair it. And 2 patients have tibia fractures. And more than 7 patients have VET. And 2 patients, it's total dislocation of the bones blood. And 3, the patient have a limb infection. Very, I will give you amputation, cut his leg. So after we could get after TTT, this 117th surgery actually is 59 patients is major amputations, 5 patients is major amputations, and 53 is the patient get better. TTT surgery it can affects the improved food suffer the temperatures. We can see this after 1 week, more than 80 the patient have a good food temperatures, but we can see this line is decreased. So I think the maybe after 2 months, only 33% have a good food temperatures. Another's, the TT surgery has a very effective in relieve the pain. We can see the more than 90% patient have relieved the pain reliefs. So this is my all the PPT. This is my tips. So I show every day. Okay. This is also my PowerPoint. Thank you.
Thank you very much, Dr. Zhao. That is wonderful. So in order to keep the timing, and we introduce our next, one of my best friends, Dr. Zhongmin from Shanghai. So he is one of the elite foot and ankle surgeons, one of the leaders, truly leaders from China, and a renowned foot and ankle surgeon. He's also one of our international members of AOFAS. And just to see how amazing numbers he's handling, his orthopedic department sees 1 million patients visit outpatient each year, and the surgical load is 60,000 cases a year. And now let's see what Dr. Shi can show us with his experiences in the diabetic foot region. All right, thank you, Dr. Shi. The floor is yours.
Dear colleagues, good morning. Thanks, Alan has organized and such good seminar for diabetic foot. So for the former panels have introduced the good technique of the TTT and shows good results. But Dr. Jiang just also show us the complications and a lot of indications on contraindications for TTT. So this time I will introduce another option for the TTT. We introduce our experience about the periosteal distraction combined with local nerve block in the treatment of the diabetic foot. The first one, we just background. Alan have shown a lot of the diabetic foot, so I will just go through. And this is for the periosteal distract technique. This is a pioneer effort also in China, and was first described by the Dr. Zheng Naixing. He now is also in the audience, and his team at the Yueyang First People's Hospital in Hunan Province, and they published their experience in 2019 and also in 2021. And this technique is improvement of the TTT. It is very safe and more easy because no need to do the osteotomy. And just insert the plate just beneath the periosteum, then rotate the screw and just do the distraction. And the mechanism is just the same. It promotes the revascularization of the dormant vessels in the extremities and improves peripheral blood supply through the slow traction. Also have the same indications for the diabetic foot, also other indications. They have such technique have the advantages of the convenient operation, minimum invasive and suitable for the day surgery and the outpatient clinic. And also can short hospital stay and the low cost. It's more cost effective, and it is just use a simple 5-hole plate. It's easy to learn. The learning curve is very slow, and a few complications with no risk of the non-union or fractures due to the osteotomy, and the patient is more comfortable and with the ability to the unrestricted activities. And Dr. Xu also published their paper in just last year. They reported that 35 patients with type 2 diabetes were included in his groups, and the average healing time is very, very short, just 8 weeks. the circulation index of the affected foot were significantly improved. They also a study just compared the PTD with the TTT, and the results just shows the PTT had the same efficacy as the TTT in promoting the healing of the diabetic foot ulcer and improving the peripheral circulation of the affected limbs. But the PTT had the advantage of a small trauma, simple operation, few complications, and convenient nursing care. And the other option is very interesting just for the anesthesia. As we all know, we maybe in the States use the general anesthesia, but in our hospital, we just do a lot of the patients use just the local anesthesia, use nerve blocks. This is the study just a compare of the effects of the combined femoral and sciatic nerve block with this general anesthesia for the hemodynamic stability and post-operative complications of patients with diabetic foot. The results shows the peripheral nerve block is a better option in patients with diabetes undergoing elective below knee surgery than general anesthesia. And this is a very interesting study, just shows blood after the local nerve block, blood flow index is in the toes significantly increased. It's a very interesting point. So our study just we just do my department is foot and ankle just do the elective surgeries, but we have another group just do the diabetic foot. So they compared the effect of just one group just use the periosteal distraction technique, and the other group is the periosteal distraction with the sciatic nerve block. And this is the inclusion criteria of the study. And also we have the contraindication for the patients. We do a lot of lab examination, including blood routine examinations, see active, reactive protein, and also do the imaging examination, for example, for the vascular CTA, and also Doppler ultrasound of the both lower limb arteries and veins, and do the X-rays, and also do some preparation before the admissions. And for the sciatic nerve block, anesthesia is simple because you use ultrasound guided. It is more precise, and our anesthesia use the implant technique to insert the needle from the outside, use the ultrasound probe, and just 10 liposomal propycaine is injected. And now we just introduce the technique for the periosteal distraction. It's more easier because just in the proximal 1/3 of the tibia, use a longitudinal incision for the skin. Then after that, just exposure the periosteum. For the periosteum incision, we use the transverse incisions. After that, just use the elevate for the both sides, for the tunnels, for insert the plate. After the plate inserted, then the plate is central positioned in the periosteal incisions. Then insert the flat-headed hollow screw through the central hole of the plate, drill a K-wise through the center of the hollow screws to fix the plate to the hollow screws. So after the plate is inserted, it is necessary to do the X-rays or just the intraoperative X-rays to show is it used smoothly. So the tip is the after the surgery, just the third day, we rotated the screw clockwise to discharge the periosteum at a rate of approximately 1.75 millimeter per day. And after 2 weeks, maybe just remove the KYs and also the plates. The adjustment was halted when the patient felt a sense of tightness or pain. So for the post-operative evaluation indications, we just did a lot, just observed preoperatively and 2 weeks, 4 weeks, and 90 days after discharging. And also we recorded the complications and the low limb salvage rate. Also do some follow-up. For now, we just have performed 8 cases of the periosteal distraction and 5 cases of periosteal distraction with the sciatic nerve block, and the study is just still in progress. So now we will show our typical case. This is the 17-male man, older man. The patient was diagnosed with diabetes 6 months ago. So just in March this year, he experienced persistent foot pain for 3 months with a VS score of 9. 2 weeks later, the blackened ulcer appeared, and the patient underwent debridement and dressing, but the prognosis is not so effective. So before the surgery, the patient's angiography shows the atherosclerosis in both lower limbs, and the anterior tibia, posterior tibia, and the peroneal arteries on both sides appearing slender and poorly perfused. And also there's severely localized stenosis in the right posterior tibia artery, and there may be proximal occlusion in the left posterior tibia and the peroneal arteries. So on the April 3rd, we did the operation using the PTD technique, just as we shows, just a small incision, cut the periosteum and insert the plate, and insert the hollow screws with the KYs, and then do the distraction. It's more easy and more simple. So this is the, at the same time, we also do the debridement of the forefoot gangrenes. This is 2 weeks after the surgery. We just finished the distraction after also do the debridement again. But the C reactive protein is very high at that time. And this is 1 month later, do the debridement again, and we use the artificial skin grafting. And the C recovery protein is lower at that time. And at 6 weeks, we just do the autologous skin graft, and the debridement also done at that time. So this is the almost 2 months follow-up. The wound is get a good union, and also shows the good ABI measurements, and also VS score is now just 1 point. So our conclusion for the PTD distraction is a very safe technique, and it is minimal invasive, and also the learning curve is very quick. So we just recommended such kind of option for the diabetic foot, but maybe we need a more evidence-based study for the prognosis. So this is my introduction. Thanks again for all the audience.
Thank you very much, Zhongmin. It's a great talk, and I apologize that we are not going to leave any time for each talk to have any questions. So we're going to keep moving on for this packed 5 hours, and we may go over time a little bit. And let me introduce our next fantastic speakers from Singapore, Dr. Chen Yongsheng. Dr. Cheng is an associate professor and head of the division and consultant in the division of orthopedic trauma surgery at the National University Hospital. So he is the very first surgeon in Singapore who introduced the TTT into Singapore. And let's hear his experience. Dr. Chen, go ahead with your presentation. Thank you.
Thanks very much, Alan. Thank you, everyone, for giving me the opportunity to speak to you. Unlike the speakers before me, I am a newbie in terms of TTT, and I thought I'd like to share a unique perspective of somebody who has just started out doing TTT and what has been my learning journey along the way in the last 1 year. So this is where I practice in the western part of Singapore. I operate out of 2 hospitals separated by just a 10-minute car ride between the 2 hospitals. Ng Teng Fong General Hospital is where I see many of my diabetic foot patients, as well as some of the isolated trauma patients. And National University Hospital, being a trauma center, is where I see the most of my polytraumas. The reason I got involved TTT is because part of my trauma practice deals with Ilizarov, and I have seen the wonderful effects of Ilizarov in the treatment of bone defects and wound care. And this is the customary slide showing our results of TTT in Singapore, even though we are a new unit that just started doing this about a year ago. And in this talk, I thought I'll just cover a little bit about how we got started and what are the patients that we think should get TTT in our unit, knowing that we've just started out doing this. And I'd like to answer the question of whether or not this is really the game changer that we are hoping for. And I'd like to also introduce a little bit about my team who's helping me to make the dream work. So in the beginning, this was the one that really took the world by storm, already introduced by many of our previous speakers, including Professor Hua himself, and that's showing a remarkable limb salvage rate of 96% at 2 years, and with a very, very small ulcer recurrence rate of less than 3%. This is almost unheard of in any series anywhere else in the world. And so if we don't believe in statistics, what about looking at some photos? A couple of years later, talks like this started showing up on the internet and showing up in the English conferences. And this is a talk taken out of the How Deformity Course. The Deformity Course organized by the bunch of really good folks called Professor Sharma from Hull NHS Trust, whom I know very well. But really, the treasure trove is in the Chinese literature. Fortunately, I can find no better example of language and publication bias than this issue of TTT, for which I must thank Alan for so ably trying to help us bridge this knowledge gap and bring good stuff out of local literature into the knowledge of the wider scientific community. And so this was my journey in 2023, December. I had the privilege and honor of visiting Professor Hua and his unit, attending lectures in Chinese for the first time in my life, and learning about the law of tension stress, about TTT at the Guangxi Medical University First Affiliated Hospital. And then a few months later, Professor Hua came to visit Singapore, and that's him visiting the National University Hospital, as well as sharing his knowledge and his book with the members of the Singapore Limb Reconstruction Society. And about 6 months later, we did our first case, and the 6 months was the regulatory approval time needed for our FDA to give the go-ahead for us to perform TTT, bringing in a new procedure into Singapore. And this is our first ever case in Singapore for foot gangrene, non-healing in spite of angioplasty, and unsurprisingly, immediately after TTT, you can see very early on there's a remarkable changes in terms of the quality of the granulation tissue, the lack of further tissue dieback, and eventual healing in 4 months' time. And so, after our initial success, we asked ourselves this question: who really should be getting TTT? Let's see what the Chinese CAOS guidelines have to say. CAOS clinical guidelines tell us it's TTT is for all comers. If you look at this table that Alan has already shown us, TTT for whether it's type 1 or type 4, TTT is there in every row. And only unless you are mentally unsound, unfit for anesthesia, you have HHNK or DKA, or if you have no inline flow into the foot. Otherwise, TTT is there for all comers. But really, is this what we as a startup should be doing on our patients? So we had a very serious thought about this, and we finally got reminded that first, our job as doctors is to first do no harm. We don't know how TTT is going to perform in our hands because we've never done it before. And so we decided that this would be our inclusion criteria for our patients in our hospital. So we decided that there will be no TTT on any patient who's already healing without TTT. Because if the patient is already healing, there's no need to be doing this, right? Secondly, we decided very early on that we will not be doing this as an index procedure for patients with diabetic foot ulcers in our institution because we don't want to be doing TTT in patients who would heal without it. All right, so we would only offer this to patients whose wounds are deteriorating or stagnating with conventional treatment. And this is in line with what Professor Hua said in his lecture earlier on. And we will give our patient informed consent, and part of this informed consent will be that we will be upfront with the patient that we are new to this procedure and we make no guarantees about the outcomes. And we're offering this procedure to you because we think that without further intervention, you're most likely going to lose your foot. And so in this case, you really have nothing to lose, and that's why maybe we think it's a good idea that we give this a go. And with that in mind, we also decided, we were very careful that TTT will not replace standard treatment. It will just be an adjunct to our existing treatment modalities. We will not cancel or refuse a vascular referral to the patient who needs it just because we are doing TTT. We will not refuse the patient access to plastic surgery for soft tissue reconstruction just because we want to see how TTT goes. And we made it a point in our unit that the consultant or the attending will be physically present for every case. So because we had a 6 months lead time before our start of the first case, we had ample opportunity to assemble a team. And our team was designed to optimize outcomes, tackle potential complications such as fracture and pin site infections. We trained our nurses in terms of the wound care and pin site care. And we gathered a team including the specialist wound nurses, podiatrists, vascular colleagues, and plastic surgery colleagues. And we made sure that every patient of ours will receive the due vascular intervention, vascular investigation, dietitian, and endocrinology review. And so far, because we have been so selective in our inclusion criteria, we've only done 20 patients so far in the last 1 year. For 18 of them, we had successful salvage. We had one BKA for an early recurrence of a patient with a hindfoot wet gangrene. And our last case, our 20th case, just happened 2 days ago, so we're still waiting response. So far, we are cautiously optimistic. And we have done 2 contralateral TTTs for salvage of severe extensive infection. So if you look at the 19 patients whom we are more or less finished with treatment, we have managed to save 18 of them, even though we are a new unit doing this for the first time, even though we are choosing the most difficult patients to be doing this on. 94.7%, and closely approximates what even Professor Hua is reporting. So is this really the game changer that we're looking for? So to me, if this is a game changer, it must be able to challenge some of our basic assumptions towards diabetic foot treatment. And I would like to show a few cases to illustrate this. The first case, I've entitled it "The Foot That Can't Be Covered." And this is a classical patient who's diabetic, 55 years old, with a trimalleolar ankle fracture. And this underwent standard external fixation followed by interval ORIF procedure. However, of note, you can see that already, even before treatment, there was a very concerning ulcer over the medial malleolus. Unsurprisingly, at 1 month post-op, there was wound dehiscence, and before long, the implants were removed. We have extensive necrosis, exposure of the joint, the bone, the implants, and the implants were then removed. After implant removal, you can see then a diabetic patient behaving like a normal diabetic patient. What do? They get foot gangrene. So the lateral border of the foot became gangrenous. The ex-fix pins started pouring out pus. The medial border of the foot decided to start to turn gangrenous as well. And before long, there's full-on gangrene, exposed joint, exposed bone. It's a mess. So this is the MRI showing panmedullary osteomyelitis and ankle septic arthritis. And this is what we did. We put in a retrograde cement Ilizarov rod to clean out the canal, and we did this multiple times together with antibiotic laden PMMA beads. And this went on for a while treatment was ongoing. However, we were never able to obtain negative cultures. At this point in time, we were really stuck and pressed and for the next step, and we managed to convince our plastic surgeons to give it a go. My plastic colleagues, Dr. Vignes and Owen, were very brave. They gave their all and put in a 2 free flaps, one on the medial and one on the lateral side. However, this unfortunately became necrotic, and we lost the flaps about 2-3 weeks down the line. At this time, we had a TTT placed, and thankfully, with TTT placed on the contralateral limb, we were able to induce granulation, and our plastic surgeons had enough of granulation tissue for their alternative techniques of skin substitutes to take effect. So this patient had Matriderm and other skin substitutes applied sequentially, and this eventually managed to close the wound. And that's the patient at about 9 months post injury, and with the wound completely covered. So, and these are the follow-up x-rays. This patient undoubtedly still has chronic osteomyelitis, but at least we've got a painless plantigrade foot, and the tailor sits somewhat beneath the tibia. The function is not optimal, but that's what we've got. Second case is Jojo. Jojo is our 58-year-old diabetic. Already has lost some toes from previous diabetic foot complications. He came in with severe osteomyelitis and almost a necrotizing fasciitis involving the forefoot and the ankle, spreading very quickly. If you look at his MRI, it is all the bones are lighting up in the ankle and the midfoot, and this is what we have done with TTT for him. You can see even in the presence of exposed bone, exposed joint, exposed tendons, and nothing else really, we were able to get coverage of the tendons, the bone, the joints, and even bare bone that is infected with chronic osteomyelitis can granulate over. And that to me is a game changer. So bare bone, chronic osteomyelitis, osteomyelitic bone doesn't have to be removed, doesn't have to be excised, and yet you can induce granulation over that. That to me is something that was not present in my practice prior to the introduction of TTT, and that's him 5 months later, with a decent result. This is another patient of mine who has had a non-healing ulcer for 8 years. And this patient, I first knew him when I was a registrar, and he had everything thrown at him. He had exostectomy, TA release, ankle fusion, midfoot corrective osteotomy with a hexapod, and then a midfoot fusion. He had offloading frames. He had total contact cast. Everything that was known to us had been thrown at him, and the ulcer would just not heal. Finally, with TTT, I just went in to lob out a big hole in his midfoot and go under the cuboid and remove the exostosis. And then my reconstruction surgeon said, let's do a free flap. I said, never mind, let's give TTT a go. And with TTT, and this ulcer completely healed with no soft tissue transfer procedures whatsoever. And so, Prof talked about regeneration without a flap. This is a patient with a free flap, and this is a patient that we presented in Beijing last year at the World Summit Conference. And basically, it's a 42-year-old man, diabetic, and long story short, has had severe, extensive 4-foot gangrene, and as part of the debridement, has lost a significant portion of the metatarsals. The second and third metatarsals has been excised all the way to the base. And this is with TTT alone. You can see with TTT alone and nothing else. And you can see granulation growing over bare bone. The amputation stumps had grown over with granulation tissue. And we were then and tissue cultures taken repeatedly were negative, right? And so we were able at this stage to then ask our plastic surgeons to help us put on a flap. And because of the massive loss of the second and third metatarsals that were missing, 5.5 and 4.5 centimeters shortening, Dr. Vignes and Dr. Owen, my good friends from plastic surgery, took a piece of a free fibula, turned it into a double barrel, and put this in for us to reconstruct the metatarsals that are missing. And the flap also helped us at the same time achieve soft tissue coverage. All of this wouldn't have been possible if TTT didn't help us to arrest the rapid decline in the condition of the wound and the ascending soft tissue loss that the patient was previously experiencing. These are photos taken during the surgery. And that's our plate, there, holding on the fibula. And these are intraoperative X-rays. And this is how the flap looks at the time of inset and 8 weeks after post-fibular transfer. And that's how it looks like at the end of treatment. And that's its function. So that's him walking in our clinic. And that's him in the papers and all in Singapore. And so none of this would have been possible without the unsung heroes and the people behind all the work that we do. TTT is not, as Professor Hua said, is not a standalone procedure. It doesn't substitute the need for meticulous wound care and soft tissue treatment. And so these are the people who are doing the pinside care every day on so many of our patients. These are the people who come into OT to operate with us at 8 p.m. at night. That's a podiatrist working on a Sunday, coming in to help us apply complex dressings and oxygen therapy for our patients. And that's them doing. And that's our plastic surgeons doing the double barrel free flap on that patient that I showed earlier. And so there are risks and there are complications. We've had wind-side infections. We've had one case where the osteotomy kind of propagated beyond our intended osteotomy margin. But we've had our successes. And this this is the whole team behind the TTT effort in our hospital. And where do we go from here? We want to refine workflows. We want to standardize our own guidelines. We want to share it with the rest of the Singapore and in the region, like what we're doing here. We want to groom our in-house expertise. And at the end of the day, like all of you, we want to save more limbs and we want to save more lives. And we like to express our deepest appreciation to the giants of TTT who are speaking today, especially our friends from China, especially our teachers who have taught us this. And Zhongxi, Hepan, and that's the Chinese word over here, and speaks to forever building and collaboration between our two countries in improving diabetic foot care in Singapore and China and the rest of the world. Thank you.
Well, thanks a lot, Yongsheng. Amazing talks. It's very impressive cases. And thanks for the insights for anyone who's considering taking on TTT to their difficult to deal with patient populations. Thanks a lot again. So
Thanks for having me, Alan. Thank you.
Thank you. Thank you. So our next presenter, Dr. Xiaorui, he is the chief of the hand and foot and ankle division in Department of Orthopedic at Beijing Chaoyang Hospital. And he also was a visiting traveling fellow at the University of Pittsburgh Medical Center in the past, and also a international member of AOFAS. He's going to present it as an alternative, an interesting alternative instead of TTT. And let's hear about his experiences. Dr. Zhao, please go ahead with your presentation, please.
Okay, I show my. It's a pleasure to share our research on the application of spinal cord stimulation in diabetic foot today. SDS is a commonly used method for neural function regulation in neurosurgery, and it is a treatment for chronic pain. It works by implanting electrode leads into the epidural space, transmitting electrical signal generated by a neurostimulator to the spinal cord. This delivers stimulation to the spinal cord, blocking pain signals from reaching the brain. The first clinical report of SDS was in 1967, and the complete implant system entered clinical in 1980. Regarding the mechanism, it is the pain gate control theory proposed by these two professors. Studies on how SDS improves lower limb blood supply, mainly divided into two parts. The first part is to reduce vascular resistance and increase local blood flow. The other is regulating the sympathetic nerve pathway. We use SCS to treat diabetic foot mainly for two purposes. First, it can relieve diabetic neuropathic pain. And second, it can improve lower limb supply. Based on improving of blood supply, it can promote wound healing. The application of SCS provides a new treatment option for diabetic foot. In our center, the treatment of diabetic foot consists of two parts. First, it is to fully improve lower limb blood supply. Second, complete debridement to control infection and wound repair. For lower limb vascular intervention, IF superficial femoral artery and popliteal artery stenosis exceeding half. We perform endomuscular surgery. However, there are some limitations. The vessels may reach stenosis within 3 to 6 months. At the same time, due to the ulcers at the toe's end of filling. The vascular guide wire cannot reach the actual affected site. Therefore, many patients still have non-healing wounds even after endovascular surgery. Today, our conference discussion focuses on TTT for treating diabetic foot. We have conducted many cases and found some problems. The main complications are as follows. First, infection may occur in the nail track of the lower leg. Meanwhile, some patients refuse to undergo this treatment due to fear of the surgery. Based on this, we have proposed an overall process for using SCS as a main therapy for diabetic foot. For patient selection and evaluation, it includes general patient evaluation, wound evaluation, and vascular evaluation. Our preoperative education for patients includes explaining the entire treatment process, the placement SC of the electrodes, and how to evaluate the treatment effect. This is the process of placing short-term SCS. We generally choose the approach beside the SPINBUS processes of L3, L4, entering the spinal canal from the intervertebral space of L1 to 2. Usually, 2 electrodes are placed on both sides of the spinal cord midline, on the dorsal side of the spinal cord. For long-term surgical electrode implantation, we generally adopt posterior laminectomy approach. The procedure involves laminectomy at 1-1T12, and the electrodes are placed at the T10-T11 spinal level. The process as follows: posterior incision laminectomy preparation stimulator implantation. Next, I will introduce several cases of short-term SCS combined with wound management. The first patient. The right picture was his preoperative CTA. After undergoing vascular intervention, his wound showed prolonged non-healing. Here are photos of the surgical procedure. We can see that we placed 2 electrodes on the dorsal spinal dura from the T1 to L1 level. During the operation, the patient reported a tingling sensation reaching the toes, and the surgery was then completed. We performed percutaneous SCS under local anesthesia. After surgery, the patient's pain significantly relieved. The VS score dropped from 6 to 7 to 0 to 1, and sensory discomfort in the calf and foot was markedly reduced. We can also observe that the wound gradually healed about 1 month after the surgery. Here is another case. A patient received wound debridement and short-term SCS about 1 month after the operation. The wound healed. Next, I will introduce several cases of long-term cases. This is an 87-year-old elderly female patient. The main symptom was pain. After 9-month follow-up, the patient's foot showed progressive deterioration, but without pain. This indicates that no treatment can cure diabetic foot in advanced cases. Such cases highlight that manage pain and improve life quality is important, even if limb salvage isn't fully successful. Here is another patient. His left foot was amputated at our center, and he had a strong desire to save the right foot, so we chose long-term SCS. About 9 months after surgery, the condition of his right foot deteriorated, and we performed a minor amputation at the Lisfranc joint, with wound healing afterward. Although amputation finally, compared with the other side, at least the leg below the knee was saved. From July 2023 to the present, we have performed over 200 cases of short-term SCS and more than 20 cases of long-term SCS. The main complications are as follows. It can effectively improve diabetic neuropathic pain and improve blood circulation in lower limbs. Combining short-term SCS with wound management promotes wound healing. Long-term effectiveness requires strict indications for surgery and careful implementation.
Okay. Thank you so much.
Thank you. Thank you, Dr. Zhao. So we actually have witnessed the very first time the AI application of an international conference, and it works really well. Thank you very much for your presentation.